Thank you so much, Dr. Heard, for being with us today. We are super excited to talk all things cancer and epilepsy. So tell us a little bit about your platform with the Mrs. America organization and how we all got to know each other.
Absolutely. It's been my pleasure. Thank you for getting us all back together. It's lovely to see lovely faces again. So I am Dr. Takijah Heard. I'm a pediatric neurologist and epileptologist that's here in the Chicagoland area. I work at North Shore University Healthcare, and I met these lovely ladies whenever I was a part of the Miss America pageant that actually happened in Las Vegas in August. I am Mrs. Illinois. We both have our Mrs. Arkansas here. And so we got to talking and recognized that we both had a passion for healthcare and making sure that babies and kids and people live the best life that they can, despite whatever ailment or disease that they might have been diagnosed with. And so we decided that we were going to get together, and it is my pleasure to be able to do this soon, because it's only been about a month since we last saw each other, to actually get this podcast done on podcast day.
I know, super exciting. We're so happy to have you here. I know your focus is in epilepsy, but today I wanted to start by talking a little bit about brain tumors and some of the symptoms that one might have when a brain tumor is diagnosed. I know a lot of people ask me how we knew that Nora had a brain tumor, what was her first symptom. I know hers was a bit unconventional, and I would like to talk a little bit about what you might see as initial brain tumor symptoms.
Yeah. So oftentimes, as a neurologist, children may come to me for various symptoms that they may sort of experience that may be a little bit odd. And as a parent, you sort of may just notice that they may be a little bit more clumsy, especially if it happens to be somewhere near the balance center, which is the cerebellum in the back of the brain. They may sort of experience headaches just because a brain tumor may sort of be something that's a space occupying lesion or a larger area of the brain. It may be pushing on various areas of the brain, thereby causing dysfunction to those areas. So they may have slurred speech, difficulty seeing, times in which they have, sort of weakness of a muscle group. The way that they walk may sort of change. So those are various symptoms that may occur if a brain tumor happens to occur. And it usually has to do something with the location as to where the brain tumor actually exists.
I think those are all really good signs and symptoms of brain tumors. Nora developed a right-sided facial paralysis because her tumor was right on her facial nerve. So I don't think that many childhood tumors are diagnosed that way. At least that's what they made it seem like whenever we were diagnosed, just because it was a bit of an odd presentation. They thought that she had Bell's palsy, even though she was a bit young for that. But overall, we eventually got our diagnosis, and would hopefully help other parents to realize sooner maybe that there's something else going on other than just random symptoms. So tell us a little bit more about your epilepsy journey as a neurologist and what all you're doing in your community. I think all these things are so fantastic. Kids with brain tumors can also develop epilepsy syndromes and develop seizures due to their brain tumors and late side effects from brain tumors. So I'd love for you to talk a little bit about that.
Yeah, so epilepsy generally is whenever you've had two unprovoked seizures. And so seizures can sort of present themselves in any way that sort of goes along with abnormal activity coming from the brain. Most times people sort of are used to what they consider to be grand mal seizures or generalized tonic-clonic seizures, in which everything sort of jerks and shakes all over the body. But seizures, especially if it comes from a brain tumor, comes from a portion of the brain. That portion of the brain is where there's dysfunction in that area. And so oftentimes a seizure may sort of be with, just facial twitching. And that facial twitching may honestly be on one side of the face. And during that time, they sort of may continue with that facial twitching. Sometimes it can start to grow, and that facial twitching may be of the eye, as you see me blinking, may sort of turn into something bigger, and they may end up having jerking and shaking on one side. We tend to notice more of these partial seizures or these focal seizures in brain tumors, just because that brain tumor lies on a focus of the brain, and that focus ends up having abnormal activity that leads to these seizures. Sometimes they happen and they go from that focus, sort of goes into something bigger, and then turns into a generalized seizure with generally everything in the brain happens to have the dysfunction that leads to the seizure. And so usually that's how the pediatric or the brain tumor sort of occurs with a seizure. So that's how usually that presentation happens. And then we usually go backwards, get an MRI, and then usually identify the brain tumor and then find the best treatment for that person based on the brain tumor type and the degree.
That's super, super great information. I think that having a general understanding of how things work oftentimes helps us to be able to better diagnose and understand why things occur within the brain. So what have you been doing in your local community that is notable, or things that you are excited about doing, upcoming things? Tell us about all the work that you do over there in Illinois.
Absolutely. So as a pediatric epileptologist, my passion is epilepsy, and there's an epilepsy foundation in every state. So oftentimes the epilepsy foundation that I'm affiliated with is the Epilepsy Foundation of Greater Chicago. I'm there as a board member. As a board member, we oftentimes have walks to sort of increase epilepsy awareness. We just recently had a walk last weekend. We will have another walk on October the 12th, and then there's usually a time in which we have an epilepsy conference. The Epilepsy Consumer Conference is for those that consume any type of epilepsy and education about epilepsy, and so this is open for physicians as well as pharmaceutical reps, or mainly for the patients and the parents to sort of come and learn a lot about epilepsy for their child that they're the caregiver for, or for that patient themselves that has epilepsy. We have a very open forum where whether it's neurologists, epileptologists, physical therapists, occupational therapists, neurosurgeons, are all there to talk and sort of learn a little bit about epilepsy and ways in which all of these people can sort of care for those that have epilepsy much better. Throughout the year, we oftentimes have various events that are quite helpful for the Chicagoland area. And we definitely try to move around the Chicagoland area to make sure that every community actually has something that's nearby and local for them to attend.
You're a busy lady.
Yes, absolutely.
I don't know if Tiffany, if you have this in your lineup at all for what to talk to her about, but I was hoping to talk to her a little bit about the effects of, say, someone who's had brain surgery or brain radiation on, like, as for a childhood cancer, do you see an increased incidence of seizures in that type of population?
Believe it or not.
Yeah, so sometimes the tumor itself can cause you to have seizures, like we sort of talked about, and that's maybe their presentation. But sometimes the treatments itself can cause you to have seizures as well. So sometimes radiation, because it's radiating both the good and the bad, sometimes we'll get things that are much more focused, but sometimes we'll end up getting some of the natural tissue, and you may have seizures after you've had radiation. And oftentimes, when we have kids that have childhood brain cancers, they're on seizure medication, either prophylactically to prevent the possibility of radiation-induced seizures, or that was their presentation and it's used sort of as a treatment either way.
Well, of course, as a profession, Tiffany and I both take care of adult cancer patients, but we also see a lot of patients who are long-term survivors of childhood cancer. So sometimes these are people who still have some of these same issues later on in their life, and many of them have long lives, fortunately, with all of the modern technology and treatments that we have available, but not enough. Which is why we're, talking about childhood cancer and fighting for cancer research advancements to hopefully try to minimize late effects of those treatments on children and other people who have had to undergo cancer treatments.
Mm-hmm, mm-hmm.
So we know that, brain tumors are not particularly common. There's 47 kids diagnosed every day with some type of cancer. Brain tumors are about 20% of those diagnosed. So to a parent who might be worried about a condition such as a brain tumor or even epilepsy or something like that, what would you say the steps are to getting this evaluated? And say that somebody kind of blows off their symptoms and their concerns, what would you suggest that the parents do in these situations?
So I think that the biggest part is trying to be the advocate, as a mom or as a caregiver. The biggest thing is to try to be an advocate. Trust your gut. I mean, oftentimes if you feel like this doesn't feel right, then oftentimes you are right. And don't feel bothered by actually getting a second opinion. So if you are dismissed by one person, then definitely continue to bring that up, especially if those symptoms continue to exist. Oftentimes it's easy and simple enough to get an MRI. So going to your local provider, and that may be your pediatrician, or that may be your internist, that may be your family medicine doc, and then sort of asking based on the symptoms that you are concerned by to try to see if we can get an MRI, something that's easy without radiation. And that way we can evaluate and see if there happens to be a brain tumor or something of greater concern that requires, some extensive treatment and specialists to get involved. Furthermore, you can also get referred to a specialist, and that specialist can sort of get things done and move things along much faster just as well. But I think the biggest part is advocacy and sort of trusting your gut to know that, hey, I may need to have this looked at and evaluated further.
So I know you talked a little bit about what different types of seizures, you can see, and I was wondering if you could talk a little bit about how that can affect their life, like how could that affect them at school and at work, like how with symptoms that would prevent them from being able to work, or things that maybe they need help with to live a normal life and perform normally at school.
Yeah, my goal and my desire is to make sure that regardless of their age, they're able to sort of function just as, children and people that don't have epilepsy. So usually whenever it comes down to anybody that has epilepsy, if they're well controlled, it's only a few things that I usually ask them to be cautious with. My hope is that their epilepsy is controlled and they don't actually have any additional seizures. But if they were to have a breakthrough seizures, I want them to be in a very comfortable place for them to have that breakthrough seizure. So I do ask them to always take showers. And to avoid taking baths. If they're going to take a bath, I usually ask that somebody's in the bathroom with them. If they were to have a seizure, I just didn't want the water to be the thing that sort of causes more problems than the seizure itself. I also ask that they never be behind a closed and locked door. So we ask, our kids and other people to make sure that privacy is just the closed door. Locking the door oftentimes can delay somebody getting to them if they're in need of medical attention because they have a seizure. Outside of that, for our older people and those that are driving, whenever they've had a seizure, oftentimes it depends on the state. So certain states will allow you to have a loss of consciousness, and then you can't drive for 3 months. Sometimes it's 6 months. And that loss of consciousness could be for multiple reasons, but obviously seizures sort of fall into that category. It could be because you have an arrhythmia. It could be because you had a concussion. But if there's a loss of consciousness, usually we will pause on you getting behind the wheel of a car for 3 to 6 months. And oftentimes that can change the lifestyle of some of our people that have epilepsy, and that they're trying to get back and forth to school or getting back and forth to work, and needing that public transportation is something that would be new to them because they're used to driving themselves personally in their car back and forth. Outside of that, heights is another thing, and that's only usually problematic for those that sort of are hikers and climbers. But I usually try to ask that people that have epilepsy to always have a buddy with them, because it's just so unpredictable as to whenever the seizures can occur, and having somebody nearby to get that extra help of that extra medical help can be great. But some people don't necessarily like others around, and that's okay. And they have that independence. And so sometimes I'll ask if they want to be alone, and that's their personality, that sometimes they can get a seizure dog. So these are seizure service dogs that sort of know that they're having a seizure. They know to bark, they know what to do. And those things can be helpful to sort of help with independence further. Sometimes I ask them to get those, some type of jewelry, whether it's a necklace or a bracelet, that if they were to have problems, a stranger could sort of figure out who to call, what's going on, and then get the appropriate medical attention.
All super.
Thank you for sharing all of that.
Yeah. So I have, to go back a little bit about when you were talking about scans, about getting an MRI, I've found that here at our local children's hospital, they, for some reason, are more inclined to do CT scans, which I have recently figured out also has a pretty high risk of causing a brain tumor in a young child. And do you find that that is an older practice, or maybe something that is standard of care that just hasn't been updated? What do you find is the reasoning for that?
So for the younger kids, it's oftentimes fastest to get a CT scan. A CT scan is going to take you all of 15 minutes. However, there will be a lot of radiation, 100 to 1,000 times more than that of an X-ray. So that radiation over time for an 8-month-old getting a CT scan, and then maybe at 18 months, if they have to get repetitive CT scans, that exposure of radiation can be much for them. MRIs are just like any other picture, just like a picture you can't necessarily move, otherwise the images are going to get blurred. Oftentimes kids will have a hard time sort of lying still, and getting an MRI may require sedation to keep them still. And so most kids around the age of 7 is able to sit still for this 45 minutes to an hour long MRI. But anywhere between, I'm going to say,
sedation has its own risks, of course.
And sedation has its own risk, sedation has its own costs, and sedation has its own resources. Right. Now, not only do we need a radiologist, we also need an anesthesiologist to sort of care for a child. And so usually that's why the older practice of using head CTs are there, just because it removes the hour-long sitting, the sedation that's required, the risk of sedation, which are minimal but still exist. And so that's why usually head CTs are done sort of quickly in the ER as a first pass.
Makes sense. What about, do you have any recommendations that you tell people routinely for their nutrition and their sleep habits and things, as far as things that may lower or decrease their risk of repeated seizures?
Yeah, good question. So there's things that can lower your seizure threshold, and oftentimes sleep deprivation is a huge one. So for our older patients and for an adults, just having, the normal lifestyle of possibly being sleep deprived because we're stressed out about a thing, or we have kids, or we had a exam, or we're sort of out sort of having a good time, can be detrimental to certain people. For certain types of epilepsies, there may be times in which flashing lights can be bothersome. So going to a concert and having the flashing lights, the strobe lights, can be bothersome for certain people just as well. And then those things are something that can be sort of bothersome to certain people. And so those are things that I sometimes will mention as things that may lower your seizure threshold. Furthermore, the very obvious one is missing your seizure meds. So doing what we can to make sure that we have an alarm on, to make sure that we don't have epilepsy. We sort of have a lapse in our medication that leads to an epileptic break. And so making sure that they can take their medications as needed, usually twice a day. If not, then I try to give them an extended release formulation that will allow them to take it once a day for their lifestyle. So those are some of the things that I usually will do to make sure that their seizure threshold is as optimized as possible. And then lastly, for our older adults, is just alcohol and illicit substances. Those illicit substances, as well as alcohol, will usually lower your seizure threshold and make it quite confusing as to what one should do if they sort of are there to give you some rescued medical attention. I'm not sure if you're drunk or if you're post-ictal, and what shall we do to make things better.
Speaking about
what about the, is there any kind of supplements or nutrients that they need to make sure to include in their diet?
Oh, yes, thank you. So oftentimes you may hear about various diets that can be more helpful for those that have epilepsy, and you may hear about the ketogenic diet. You may also hear about the Atkins diet. You may also hear about the modified Atkins diet. All of those diets sort of go along with the premise of being more in ketosis, something that diabetics sort of tend to go into that can be a little bit dangerous. And usually it's something that we put you on the ketogenic diet in a little bit more of a medically controlled fashion. So it's not something that you get in full ketosis and without medical attention. The ketogenic diet can be very fat rich, and you sort of have to be very careful on how to get into ketosis. And for those that have a very great diet with a lovely palate, this is not a very palatable diet. I find that the ketogenic diet is super helpful for those that don't eat orally very well, that may be eating through a G-tube, that may get a Ketocal, so it's a special formula because they have a G-tube. Just because you're doing something simple like eating a piece of candy will throw you out of ketosis, thereby sort of bringing you back to possibly having the seizures that you've been trying to prevent with this diet over a long period of time.
So a minute ago, you talked about a post-ictal state.
About the keto.
So I have several patients who say that they have seizures, quote unquote, and whenever they come out of the seizure, they're fully conscious. Is this something that can happen with epilepsy? Is this something you see frequently? Is this maybe just an odd phenomenon that some people have? So I'd just like you to talk a little bit about the post-ictal states of seizures.
Yeah, so just to sort of break down the word, it's sort of like words. So ictal is the ictus, is actually the seizure itself, and then post-ictal is just after the ictus or after the seizure. Usually, the seizure is generalized. Usually, if it's generalized, you lose consciousness, just because generally the entire brain is involved. Post-ictally, it depends on how severe the seizure was and how long the seizure was as to how long and severe the post-ictal state is. They usually sort of coincide. If it happens to be sort of a long, very involved seizure, their post-ictal state usually sort of matches that. For somebody to have a very involved seizure and then sort of quickly come back to their baseline, it's not common. So that would be one thing that I would sort of look into, is to sort of get a general idea of how long do we think the actual seizure was versus how long we think that the post-ictal state was. It's sort of like a waking up period.
If somebody's thought that they've had a seizure, they come into the office and report to us, hey, I had this episode of shaking and unconsciousness last night. What would be our threshold to send a patient to neurology for possible seizures? Would you want this episode to happen one time or more than one time? What would be the indications for one to get a neurology referral?
So, if they've had that one episode, I would like to see them sooner rather than later. Just because once they have those two unprovoked, sort of seizures is whenever they get that diagnosis of epilepsy. A bigger thing is, sort of the safety issues. Is this person someone that lives alone? Is this somebody that drives a car? Is this somebody that cares for somebody that now is putting two people's lives in danger? So those would be some of the things that I would ask about, or sort of give me a different change in the urgency of getting that person evaluated. The evaluation for that may sort of end up being an EEG. That EEG may be something that's prolonged with the video. So if it's something that happened, like you said, for example, in the middle of the night, we could put an EEG on, electrodes all over their brain, all over their head. We would wrap their head, and then they would have a webcam in the room. And then we could sort of see as they sleep, hey, the thing that they're concerned by that happened last week, it happened again this week. And I see it. The EEG had brain changes that went along with it. And there was jerking and shaking all over at 3 o'clock in the morning that lasted for 6 minutes. So he was exactly right, or he or she was exactly right. And we have a documentation of that.
So am I right about that it can be difficult to catch sort of the actual activity on an EEG if it's not currently happening, if they had an episode at home and they got to you like a week or two later?
Yeah, it can be.
Would you still be able to detect that?
So EEGs are dynamic studies, meaning that they let you know what's going on at that time. It's sort of like taking a picture. If I take a picture of you and you're smiling at that picture, It doesn't mean that you weren't frowning before or frowning after, right? So it doesn't leave a mark on the EEG, but I sort of describe EEGs as one would describe music. So if you think about music and there's just scales, that's a normal EEG. No notes on the page, nothing's happening. However, if there's a page with scales and notes on the EEG, that lets me know that you're capable of producing a song with a rhythm and a melody and a cadence. And that song is what I consider to be similar to a seizure. So if you're able to produce notes on an EEG, that lets me know that you're capable of producing a song, which is a seizure. And that's how EEGs are usually quite helpful. But just like it can sort of happen to come and then go, the longer the EEG, the better. We tend to get a little bit more information whenever they're longer, but the hope is that we're able to capture the thing that they're concerned by, and then we can sort of say that it happens to have an EEG change or it doesn't, to give the diagnosis of epilepsy or seizures or not.
Okay, well, that's one thing that I think I heard a lot in clinicals and even afterwards with people, is that, well, I think I had a seizure, but then they said I didn't, or they said that they couldn't find it. So that's what I was wondering about, as far as the time frame in which they would need to, if there was a time frame in which they would need to get to you quickly in order to detect it sooner or later, or does that matter if it's a month after it or a week after it?
No, actually, sometimes it's a little bit better whenever it's a bit later. Yeah, that definitely does make sense. I sort of give the same semblance or the same scenario as your computer. Your computer sort of having these glitching episodes. You do a hard restart and your computer behaves a little bit better right after you do that hard reset. And so sometimes it is better to do it a week later or a month later, because the computer can sort of get back to having those episodes of glitching more frequently than after it's had that hard reset, which is usually that seizure. So even if it's been a week or a month later, it's frequently helpful to actually get it EEG later.
Do people with epilepsy tend to have more migraines and headaches at all? Is that correlated at all with that?
Maybe, not necessarily. It's usually one thing at a time in general. Not guaranteed. People that may have brain tumors may sort of experience migraines and headaches a little bit more frequently. Those migraines and headaches are oftentimes what we're looking for. As a neurologist, migraines and headaches are much more common than tumors. However, they're going to possibly present themselves similarly. So emesis and vomiting, especially in the morning, usually goes a little bit more along with brain tumors than it does with migraines, but they can happen in both. So usually if you have a headache, we oftentimes will try to get an MRI, and we're ruling out any type of brain tumor by getting that MRI, because a migraine is usually a diagnosis of exclusion. We've excluded every other diagnosis out, including a brain tumor, and giving you the diagnosis of migraines.
So I've got you on the phone.
Oh, go ahead.
I was going to say, while I've got you on the phone and you're a pediatric neurologist, my 15-year-old, she doesn't have anything seizure-like really, but she has tremors just kind of all the time. And she always asks, well, what do we need to do about this? And I'm like, well, probably nothing. It's just a mild kind of essential tremor. Do you find that to be something that's sort of common, or that potentially could eventually need to be more evaluated?
You can get it further evaluated. I usually find that the tremor is essential and usually does not require any additional treatment. So the evaluation would end up being getting an MRI, sort of double checking the movement centers that are deep within the brain are not bothered. And then oftentimes I'll ask the child or the person, how bothersome is this for you? Are you having trouble eating soup and cereal? Do you find that you're having trouble with your writing to where it's very jagged because of the tremor? And if that happens to be the case, then usually I'll treat it. But most of the time, it's maybe not necessarily worth having to keep up with the medication, deal with the possible side effects. And so I usually ask the person themselves, how bothersome is this tremor for you?
Well, she is an excellent artist and her lines are beautiful. So I think that she's probably going to be just fine.
So what is the typical age of onset for a patient who develops epilepsy? Is it common to develop as an adult, or is this mostly diagnosed in children? How is that kind of diagnosed?
Yeah, so I feel like epilepsy in general are developmental, especially in the pediatric population. It makes my job, sort of beautiful in the sense that there's a time frame in which they may have epilepsy, and then usually as an adult they do not. For example, there's times in which we have special types of epilepsy that actually occur in utero, meaning that the parent or the mom sort of feels a little jiggle in their belly frequently, and it's sort of very rhythmic and seems to be a little bit predictable. So they can come as early as in utero. They can come as soon as they come out of the womb, so hours of life, days of life. Those neonatal seizures are sometimes, hard to treat, but usually they sort of don't have them as a toddler. There's sort of toddler type of seizures that happen, like Pignatopoulos syndrome, or then later on, whenever they're sort of elementary school age, they may have a different type of epilepsy, and that's absence or the petit mal seizures, where they sort of zone out. And oftentimes we're trying to figure out if they're having absence epilepsy, or they sort of inattentive and they have ADHD, or they're just sort of ignoring the teacher and not really very interested. As they get a little bit older and get into the teenage years, there's something called JME, which is juvenile myoclonic epilepsy. And they sort of present with these myoclonic jerks in the morning and then have generalized seizures throughout life. So it depends on the type of epilepsy, but there definitely are developmental epilepsies. And what makes my job very rewarding is the fact that they usually will have it during a period of their life, and then usually not necessarily have to see me as an adult or throughout their life.
Well, that's a relief. It's not always permanent.
Yeah, that's super interesting.
Mm-hmm.
My last thing I was going to ask you about is febrile seizures. I know a lot of younger children may have a febrile seizure, and a parent could be extremely worried, and it's obviously alarming whenever your child has had no evidence of seizures or epilepsy, or maybe no family history, and then all of a sudden your child's got a high fever and they've had a seizure, do you recommend that they go to the ER for this kind of seizure? Do you recommend they be monitored at home? What would you recommend for maybe a parent that doesn't know anything about seizures and their child's all of a sudden had a random seizure in the middle of the night with a fever of 104?
Yes. So I think that febrile seizures are very, very common. Would you say, Virginia?
I said yes, and then how would they follow up? Like, what would they need to watch for after they had that and been evaluated for that?
Yeah, so just like we were talking before, febrile seizures generally are developmental. They happen at a developmental time in their life, usually between 6 months of age and 6 years of age, with the peak being around 4 years of age. So it is devastating. These are usually normal children that has developmentally normal milestones that have been met, and then they'll sort of have a very high fever. It's usually the rate of rise of the temperature, not necessarily the temperature itself. So just like 104 can lead to a febrile seizure, 101 can lead to a febrile seizure. It's very terrible and hard to see. It's very devastating and very scary for the parents that are watching it. So usually 911 is going to be called. An interesting thing that I'm hoping that a lot of people sort of gain from this is recognizing that febrile seizures generally last a little bit longer than generalized epilepsy seizures. Those febrile seizures can last, 7 minutes, 15 minutes. They're more abnormal whenever they last about 30 minutes. So we're bothered as physicians whenever they're 30 minutes long, but sometimes they can frequently last up to 15 minutes. Commonly, the most common is usually they last like 2 or 3 minutes, to be honest. But those are 2 to 3 minutes of an eternity if you're watching your child seize. And they can sort of do a little bit of anything. They may be sort of jerking and shaking more often, or they might be super still and stiff during that time frame. So if you see something that's abnormal, whatever that abnormality may be, just recognize that that could be a seizure. Calling 911 is helpful. Calling your pediatrician is helpful. And then usually the 911 will double check on the duration of it. Sometimes there may be times in which there's changes in their vital signs where they may sort of turn a little bit blue or dusky in their lips or face, depending on how long it is and how severe it is. Sometimes we'll have to give them a nasal medication to stop the seizure, or rectal medication to stop the seizure. It's usually a benzodiazepine to get those things to stop. But frequently calling the 911 and getting medical attention is quite helpful for it. It usually does not require additional medication after they sort of get over that febrile illness. There are cases in which we will start them on seizure medication, but I would not say that that's a common thing. Most of the time, whenever they get past the age of 4, they do much better, not having febrile seizures as often. And we usually will try to ask that we give them Tylenol and Motrin around the clock anytime they sort of develop any type of febrile illness, or just the illness that mom or dad recognizes that they're not acting their best.
Well, that's definitely something that people would be very interested to know who have little children.
It happens quite often. It's the most common reason that a neurologist ends up in the ER.
I did not know most of that information about febrile seizures. That's super interesting and very helpful. And we just want to thank you so much for being here with us today. I'm excited to be back on the podcasting land, on the air, talking about all things pediatric cancer and all things pediatrics. We're so thankful that you joined us, Dr. Heard. I hope that the listeners have had a great time hearing about you. And if they want to learn more about you, about your mission, about your platform, where can they contact you or look you up on Facebook or all the social things or website? Give us all the details.
Absolutely. So if they're interested in learning a little bit more about epilepsy, then it's easy to get me on either Facebook or Instagram as simply the Baby Brain Doc. So Baby Brain Doctor on Instagram or on Facebook. And so it's BABY Brain, BRAIN, Dr. DOCTOR. So those are going to be the easiest ways to get in contact with me, in which I sort of try to increase my platform talking about epilepsy awareness for all that would like to know a little bit more about it. 1 in 26 people may have epilepsy throughout their life. That's sort of anywhere from day 1 of life to day 100 years of life. So with that all being said, thank you for us talking. Thank you for us getting back together. Thanks for being the beautiful queens that you are, literally and figuratively, and continue to change lives for those that have pediatric cancers and cancer in general.
Yes, and I think that the most exciting thing that came out of the whole Mrs. America pageant week that we got was these connections that we're making, that we get to share platforms across the country. I have another one, my roommate actually, that I'll be speaking with next week about another topic. So I think that's why we all do all of this, is just to help make a difference, and making these connections has been the best part of the whole experience.
Absolutely, absolutely. So I look forward to doing this again, and thank you, ladies. Keep doing what you're doing.
Yes.
In the beautiful way in which you're doing it.
All right, guys. Thanks for listening, and thanks for joining us today. Thanks for joining us today on An Unexpected Fight podcast. We'll see you soon.
All righty. Bye.